Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1. Extract 1, questions 1 to 12. You hear a doctor in an emergency department talking to a patient called Gail Kennedy. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Mrs. Kennedy?
Yes.
I'm Dr. Jarvis.
Hello.
Sorry to keep you waiting.
Okay.
Now, can you tell me what's brought you here today?
Well, I got back from holiday 2 weeks ago and I've been feeling awful ever since. It was a long-haul flight because we'd been to South America and when I got back I felt awful. I thought it must be jet lag, but brutal. Much worse than I remember having before. Anyway, I thought I'd get over it, but it actually got worse. After a few days, I was getting bad chills and non-stop shivering and achy muscles. I just felt lousy. I mean, normally I'm pretty healthy. I don't get a lot of illnesses. So I started to worry. I thought maybe I got meningitis. Right. So I rang the doctor. When I told him where I'd been, he said I should come in and see him because it might be malaria. So I said, well, it can't be because I've been taking Malarone. I started on that 2 weeks before going away. I tried Lariam a few years ago, but it gave me really odd dreams, so I didn't want to take that again. Anyway, the doctor said some sorts of malaria are resistant to these drugs, and I know I did get a few bites when we were there. He gave me some pills to take for 3 days, just in case it was malaria.
Right. Can you tell me what they were?
Oh, Art something.
Artesunate.
That's right. And something else. Hang on, I've got the box here. Mefloquine.
Okay.
So I went home and I took the pills, but I didn't feel any better. In fact, I got worse. I felt really weak and I was sweating buckets, just dripping with it. I finished the pills yesterday morning. Since then, I've been really bad. I haven't been able to keep anything down. I was throwing up all day yesterday and had the most splitting headache. I've never had anything like it. So I rang the doctor again and he said the blood test had come back negative. But if I wasn't feeling better today, I should come into the emergency department and get some more tests done.
Right. Well, I'll just do a brief examination.
Okay.
You want to pop over there? Okay, so your skin's a good colour. I can't see any sign of jaundice. And your breathing's sounding pretty good. You haven't had any episodes of breathlessness, have you?
No. But yesterday, my heart was really racing.
Yes, there is some evidence of that now.
And something else. All this week, I felt as if there was something scratchy in my eyes, like sand or something, and they feel really dry.
I see. And have you had any abdominal discomfort?
Well, there's no pain, but I don't have any appetite. I can't really keep anything down, like I said.
Right. Now, apart from taking the anti-malarials, did you have any vaccinations before you went away?
Yeah, I had all the injections. Typhoid and what else? Not yellow fever, because I'd already had that before. But I did have one for hepatitis A.
Yeah.
And they were fine. I don't usually have any problems with things like that. Then, while we were away, I did get cold sores all over my upper lip. I've had them before, and I'd got some over-the-counter stuff for them, so I just used that.
Right.
Apart from that, I was fine during the holiday. I'm normally very healthy.
Uh-huh.
I did have breast cancer a few years ago. That was in 2011. I had a lumpectomy, so I was taking tamoxifen for 5 years. But I don't have to take it now.
Okay. So it's possible that this might be a reaction to certain drugs, but we'll need to do some more tests first.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, I suppose you're George?
Yes, and I believe you're Dr. Mark?
Oh, yes, I am. What brings you here today?
Well, I'm having this redness in my, in the white part of my eye, actually.
All right.
I think, I don't know what it's called. Is it called the conjunctiva or something?
Mm-hmm.
It's quite swollen, and,
I can see that,
yeah. I've been having more tears than usual. It's, more than tears, I think it's, sometimes I can feel that it's sort of like a yellow kind of discharge.
Yellow?
Yeah. And it crusts over the eyelashes, and, when I go to sleep, it's not, during the daytime, it's not really bad, but when I go to sleep and I wake up, you can see that, it's quite thick.
Do you have any particular sensations there?
It's quite itchy, and I feel sometimes burning, in the eyes, and I'm not sure it's because of this discharges or whether anything else is happening. I feel like my vision is quite blurred. So, and I mean, I believe the sensitivity to the light has changed as well. It's how do I call it? It's like stubby.
Stubby.
Yeah. And I just don't have anything else, just these things, and I have other allergies and everything, but I don't know whether it is associated with it.
All right. Allergies, you said?
Yeah. I'm allergic to pollen.
Dust?
Not very much. It's hard to, pollen is, it's tested, and, I am positively allergic to pollen.
Okay.
And, sometimes I get common cold, and Not like, not a lot. So I would love you to do, like probably an eye examination, and
We could
it's
do
just,
that. There is a thorough history collection in the laboratory.
Yeah. No, so I believe I'm gonna have to give some blood or something like that.
No, you don't have to.
Yeah.
You can rest assured.
Yeah.
Always do keep the eyes clean, please.
Yeah. Yeah. I'm pretty, like, I've had it when I was a child, and I remember, wash my wash the eyes with clean water. I change the pillowcases every day, morning, and I think I have to do I infection goes away, but it's not my expertise, it's more of your expertise. So I do the basic do's and don'ts, and I don't touch both eyes, or with the same finger, or I don't rub.
Right.
I just don't I don't want to spread it to the other eye as well. So, and hopefully, like last time when it happened, the doctor gave me some eye drops, and it's just the regular things, I believe, but I feel like I'm a bit of a fraud coming in just for a bit. It might be something silly, but
You did the right thing.
yeah.
So I would ask you not to put a patch over the eye.
Yeah.
It might worsen the infection.
Yeah.
And protect the eyes from dirt,
Yeah.
especially from the irritants you mentioned.
Yeah.
And did I forget to ask you to take enough rest?
Well, I've not been doing much. I started off using, when it went, on the first day, when it happened, I thought I'd just, look at it, and I don't want this to go bad or something. So I used an over-the-counter eye drop. I tried it to start with, and now. My vision is a bit blurry, so I'm not, watching TV or anything. I'm just get a bit of rest. And
I'd also ask you to stay away from work for a few days if it's okay.
well, that's not really a bad thing. If you're happy to give me a sick certificate, I'm physically feeling really good actually, but it's just I don't think it's safe as well. I work in a chemist as well. I'm not a pharmacist though. Actually, I just read scripts and things and assist a pharmacist. So I don't think it's safe enough with this condition. I should work. So
For that, I'll prescribe you some antihistamines as well.
Yeah.
Okay.
Yeah, so I think that'll be good. I'll probably take some rest and take the medications. And do you want me to see me next week, or just you want to know how it goes, or like?
How about in 4 days' time?
Okay, cool. So I'll try it, and if I can work it out, I'll do it. Great, thanks. Nice meeting you, Doc.
All right. Cool. Yeah.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear two trainee doctors doing an activity at a staff training day. Now read the question.
So, what did the trainer say we have to do?
Well, we've got to look through these case notes, 10 sets in total, and decide which of the patients should be referred to the consultant as a matter of urgency and which can wait.
Oh, right. And did I hear him say there's a limited number you can refer?
Not exactly. He said that we should put them in rank order according to the severity of the symptoms and other factors evident from the case notes. Once we've agreed on our list, we have to go and compare with another pair of trainees.
Okay, let's get started then.
Question 26. You hear a radiographer talking to a patient about her MRI scan. Now read the question.
Come in, Mrs. Brown, isn't it? My name's Ted, and I'm going to be doing your MRI scan today. Now, can you get up on the table for me?
You know, I'm really claustrophobic.
Well, this is a new piece of equipment. The diameter is much larger, so it should make it a little more comfortable for you. You'll also have this call bell, so if you need me at any point during the test, you squeeze that, okay?
Okay.
Now, your scan's only going to take about 15 minutes. Are you okay with that?
I am.
Okay, let's get started then.
Question 27. You hear two nurses discussing an article in a nursing journal. Now read the question.
Did you see the article about research on strokes and sight problems in the latest nursing magazine?
Yes, I found it interesting that there's quite such a high degree of visual impairment after a stroke.
Yeah, but I think I could have told them that without an expensive research study.
Well, you need evidence to get progress in how people are treated, and now there'll be a push for all stroke patients to have eye assessments as a matter of course.
It certainly makes a pretty solid case for that, especially as there's plenty that can be done to help people if early screening diagnoses an issue.
Absolutely.
I was just sorry the article didn't provide more detail about the type of sight problems that are most common after a stroke.
Well, there's a reference to where the whole study's been published, so you could always find out there.
Question 28. You hear two hospital managers talking about a time management course for staff. Now read the question.
The uptake for the course in time management for staff has been disappointing, hasn't it?
It has, but I'm not exactly sure why, because everyone seems to know about it. And we asked for it to be changed from a 4-hour session to 2 2-hour slots to make it easier for nurses to be released from their wards. But apparently that wasn't possible because it has to be done a certain way.
Yeah, I'm not convinced that was the problem anyway. I think once staff become aware of what it's aiming to do and how it fits together with other initiatives, there might be more interest.
Yeah, there certainly is a need, even if the staff themselves don't actually realise it at present.
Question 29. You hear an optometrist reporting on some research he's been doing. Now read the question.
I specialise in dealing with fungal eye infections. At present, treatment involves giving eye drops every hour for at least 2 weeks. I wanted to improve this process by designing a system capable of releasing antifungal drugs onto the eye over an extended period. Contact lenses are perfect for this, as their hydrogel structure has the ability to uptake and release drugs, and their placement on the eye ensures the drug gets released directly to the cornea. In order to make a contact lens provide drugs over a sustained period, I've modified the lens. I've also used nanoparticles for packaging the drugs. So, I've managed to create a system capable of delivering an antifungal drug, called nanomycin, for up to 4 hours. I now hope to increase this, and use this system with other drugs.
Question 30. You hear a consultant talking to a trainee about a patient's eye condition. Now read the question.
Have we got Mrs. Kent's notes?
Yes, they're here. She's coming in today for possible laser surgery for her retinopathy, isn't she?
Well, depending on results. And from the look of these pictures we took last time, there's been a slow improvement. So we'll talk to her, and perhaps hold off for the time being, unless her condition's worsened, because it can in some cases.
So what's the cause?
Well, we know a leak of fluid behind the retina causes the distorted vision which sufferers get, but not why that occurs. There may be a link with stress, and also steroid use, but the jury's still out, I'm afraid.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
And today I'm going to be giving you a broad overview about the incidence of congenital heart disease in Australian newborns. Certainly we know that if the mother has congenital heart disease, then her children are more likely to have congenital heart disease. We know that the older a mother gets, that this places her at risk of having a baby who has congenital heart disease. We know that if mum has diabetes early in pregnancy, and particularly uncontrolled diabetes very early on in pregnancy, that this places the baby at risk of having congenital heart disease. In pregnancy, we screen women for rubella, for cytomegalovirus, for herpes simplex virus and for Coxsackie B virus, because we know that these viral infections are all associated with congenital heart disease. So you would think that we probably diagnose congenital heart disease quite well antenatally, and we certainly know that, for instance, in Queensland, in the most recent statistics, that 99.7% of pregnant women have an obstetric ultrasound. If we compare this to Victoria, we know that in Victoria around 95% of women have an antenatal ultrasound at 18 weeks. What might come as a surprise to people is that despite our excellent techniques in ultrasonography, that in fact only around 53% of quite significant congenital heart disease is detected. And to put this into perspective for you, if we look at the number of babies that the Newborn Emergency Transport Service retrieve every year with congenital heart disease, we know that around 20% of the babies that we retrieve will be born in a level 1 hospital. Has very limited diagnostic facilities, so may or may not be able to do a blood gas, usually cannot do a cardiac echo postnatally, and therefore in these places the staff have very limited facilities to deal with a baby who's born who can be really quite ill. Around a quarter of the babies that NETs retrieve will be born in a level 2 hospital, but these hospitals again are unable to maintain a baby who needs full life support or who needs intubation and ventilation. So these babies have to be retrieved. So we see that on average around 45% of babies who are born with very significant congenital heart disease are born outside of a tertiary centre. One of the questions we get asked quite often is that why don't these problems present in utero? Why is it that the baby grows quite normally, is a good size, the mother gets to term, goes into spontaneous preterm labour, and it's only after the baby's born that we start to see problems? We certainly know that this is because of fetal circulation. So during fetal life, the placenta is doing the work of oxygenation and carbon dioxide removal, and the baby really contributes very, very little to its day-to-day survival, probably only about 8%, because the placenta is oxygenating the blood and therefore the lungs are not acting as an organ of oxygenation. Now, of course, when the baby's born, the baby has to undergo very dramatic physiological and biochemical changes to shift from fetal circulation to an adult type of circulation. And therefore, if the baby has congenital heart disease, this is the time period that we're going to suddenly see it. Now, contrary to what people have traditionally thought, the ductus arteriosus does not necessarily close with the first breaths of life. And in fact, we know from ultrasound studies that only about 20% of babies' ducts are closed by 24 hours of age, around 82% by 48 hours, and in some babies it takes up to 3 days for the ductus arteriosus to close completely. And this becomes important when we are thinking about the baby who has congenital heart disease, because the timing of the closure of the duct can affect the timing of presentation of the baby to us. So we would expect that by 3 days of age that most babies' ducts will close. So what happens if the baby has congenital heart disease? How are we going to know it, and when are we going to see these babies present with it? Well, basically it all depends upon what the defect affects. So if the defect obstructs normal circulation, then we're going to see symptoms very, very early in the newborn period, basically in the period between the time the baby's born and the time that the ductus arteriosus closes. So conditions like transposition of the great arteries will present very, very early within the first few hours of the baby being born, as opposed to some of the other conditions which appear as anatomical changes occur, such as the duct closing after 3 days of age. So this would be conditions such as coarctation of the aorta, and this can typically present around day 7 or up to day 10 of life, and typically after the baby has in fact gone home. So this might be picked up by the parents who notice that the baby is mottled, He's feeding poorly, seems cool to touch peripherally, is very, very tired and lethargic between feeds, and seems to be breathing up quite markedly. So how are we going to make a definitive diagnosis of congenital heart disease, and especially out in a small hospital or a GP surgery where they may not have gold standard tools? We certainly know that the gold standard for diagnosing congenital heart disease is echo by a paediatric cardiologist after birth, but these facilities are really only available at the major tertiary teaching hospitals such as the Royal Children's. And so until a cardiac echo can be performed, we really have to rely on our clinical signs to try and differentiate congenital heart disease from some of the other causes of cyanosis and collapse in the newborn period. And this can be really quite challenging.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear a dermatologist called Dr. Jake Cooper talking about a skin condition called hidradenitis suppurativa, HS. You now have 90 seconds to read questions 37 to 42.
Hello, my name's Jake Cooper. I'm a dermatologist, and I'm going to talk about a skin condition called hidradenitis suppurativa, commonly abbreviated to HS. Let me tell you a bit about this condition. HS is a chronic inflammatory disorder characterized by painful swollen lumps on the skin, which may break open, releasing fluid or pus. It's also called acne inversa, and in fact, sufferers often think they've got acne or pimples. But unlike acne, HS affects apocrine gland-bearing sites, in particular the armpits and the pubic regions. It's not a very well-known disease in the medical community, which is surprising, as it affects about 1% of the population, and early occurrences are commonly misdiagnosed as simple nodules or abscesses. This is unfortunate, as the condition can be very distressing for the patient. We don't know exactly what causes HS, though it seems to be linked to blocking of the hair follicles in the affected area. It tends to occur most often in younger females, and it's often found in patients who are overweight. Studies carried out into a possible link between deodorant use and HS have so far been inconclusive, but the condition is more prevalent amongst smokers, and there's some evidence that nicotine may affect the follicles. Patients sometimes worry that they've caused the condition by shaving, or possibly by using depilatory creams, but there's no evidence that either is a contributing factor. Let me tell you about one case I encountered recently. This was a 22-year-old woman called Sophie, who came to see me because she had a number of painful boils in her groin. These had been occurring with fluctuating severity for the previous 3 years. When I questioned her further, I learnt that she'd previously undergone incision and drainage of various lesions on multiple occasions at various medical centres. She also told me that she'd taken a course of an unknown oral antibiotic to treat an abscess about 2 months earlier. So I was able to put 2 and 2 together and make a connection with HS. Then we could start to think about the right sort of long-term treatment for her. When treating patients with HS, it's important to be aware of the impact it can have on them. Many studies have confirmed that patients with HS commonly experience depression as a result of their condition. Additionally, HS has a significant psychosocial impact. Patients reported feeling unworthy and unlovable, and described their lesions as ugly, smelly, and embarrassing. In some cases, symptoms may spontaneously resolve themselves for long periods of time. But both doctor and patient need to remember that there could be a flare-up years or even decades later, and that currently, treatment is limited to finding a way to manage the condition. HS may present itself in younger patients too. In another case, I saw a 14-year-old girl called Emily, who came to see me with her mother following a diagnosis of HS by her GP. We needed to confirm the diagnosis and decide on the most appropriate treatment. Her mother expressed concerns about what she referred to as Emily's unappealing hygiene. This was said in front of the girl. Now, we know that HS is notably not due to poor hygiene. While HS is a skin disease, it's happening lower in the dermis than just the surface level. In this case, Emily had a lesion on the mons pubis, which required surgical intervention. Following incision and drainage, her condition improved, but this does illustrate the need to consider not just the patient, but also the attitude of family members. In general, when it comes to treatment, once we make a diagnosis, there are multiple therapies indicated, depending on the severity of the disease and patient presentation. One thing patients often ask me is whether they need to make changes to their diet. One small-scale study followed 12 HS sufferers who cut out beer from their diet, together with other foods containing yeast, such as bread and some types of cake. And this did appear to have an effect on their symptoms. It's also known that overproduction of one group of hormones called androgens may contribute to the symptoms of HS. These hormones are linked to insulin, and foods such as milk and cheese can raise insulin levels. So reducing these types of foods might be helpful. However, a controlled diet, which leads to weight loss, is certainly recommended for patients who are overweight or obese.
I wonder. How head injury can lead to a condition like this?
I realize your anxiety. Definitely, I will help you to sort it out. But before moving further, would it be okay if I can ask you some questions?